This video contains the content of the concept of intracranial regulation and the exemplars traumatic brain injury. These are the student learning outcomes for this content. We'll address each one of these in this video, and you also have it on your Canvas site. This is an overview of the content that's going to be included in this video. You're going to learn about the immediate primary brain injuries that are caused by trauma and the secondary damage that may occur over minutes, days, and weeks after the primary injury. When you're watching this video, I want you to use the clinical judgment model to organize the information. Take notes on the content of this video. Write down the cues that a patient with a traumatic brain injury may exhibit, and then analyze these cues to determine if they're normal or abnormal. Once you do that, you have to put each cue in order of priority and then generate a solution. In other words, what is the nurse going to do? And then take action and then follow up by evaluating each one of the outcomes. There are two types of head trauma, penetrating and blunt. Penetrating trauma is an open wound injury that occurs when an object pierces the skin and enters tissue of the body, creating a deep but relatively narrow entry wound. Examples of penetrating trauma include bullet and stab wounds, as well as the impalement of an object into the skull. Blunt trauma may cause deep damage on the inside of the skull, but may not even break the skin. I put a link to a YouTube video on Canvas about traumatic brain injuries that you need to watch before class, and it gives a great audiovisual explanation of the pathophysiology of brain injuries and gives you a great example of acceleration, deceleration, rotation, and compression injuries. There are two phases of the traumatic brain injury. The first phase targets the physical injuries that occur at the time of the traumatic event. I'm going to briefly discuss each one of these primary brain injuries with you. A concussion is a traumatic brain injury that temporarily affects brain function. Symptoms of a concussion are listed down here, so make note of it. These symptoms could be delayed by 1 or 2 days after the accident, and it's not unusual for these symptoms to last at least 2 weeks in adults. A basilar skull fracture is a break in one of the 5 bones that are located at the base of the skull. Cues related to a basilar skull fracture are related to the close proximity of the skull base to cranial nerves, blood vessels, and meninges that contain CSF. Skull base fractures increase the risk of developing meningitis because of the possible contact of bacteria in the nose, throat, or ear with the central nervous system. Classic signs of a basilar skull fracture include raccoon's eyes, battle signs, rhinorrhea, otorrhea, as well as a halo sign. Cerebral contusions are bruises of the brain, usually caused by a direct, strong blow to the head. Cerebral lacerations occur when an object or a piece of bone penetrates the skull, causing a skull fracture and tears brain tissue. Contusions and lacerations can cause bleeding or swelling in the brain, and this increases intracranial pressure. An epidural hematoma is a collection of blood between the dura mater and the inside of the skull. The classic sign of an epidural hematoma is a loss of consciousness with a period of wakefulness and then a re-loss of consciousness and rapid neurological deterioration. A subdural hematoma is a collection of blood between the inner layer of the dura mater and the arachnoid mater of the meninges surrounding the brain. This usually results from tears in bridging veins that cross the subdural space. Subarachnoid hemorrhage is bleeding between the arachnoid and the pia mater of the brain, could result as a rupture of a pre-existing or traumatic cerebral aneurysm. Patients who come in complaining of the worst headache of my life, we're going to take them for a CT, and a lot of them actually have a subarachnoid hemorrhage. You'll see changes in the level of consciousness, as well as meningeal signs, including nuchal rigidity, which is neck stiffness, as well as an elevated temperature. Brain herniation is the side effect of very high pressure within the skull caused by either edema, the presence of a hematoma or a tumor, or an infection that are allowing a part of the brain to be squeezing across structures within the skull and eventually come out through the foramen magnum, which is the hole at the base of the skull where the spinal cord connects with the brain. Because herniation puts extreme pressure on parts of the brain, it cuts off the blood supply. And this is actually which makes this fatal. To avoid herniation, extreme measures are going to have to be taken to reduce increased ICP or to decompress or drain a hematoma, which is putting local pressure on some part of the brain. Patients with brain herniation will often exhibit either decerebate or decorticate posturing. The video that you need to watch gives you a very good example and explanation of diffuse axonal injury, so I'm not going to get into it. You just watch the video. All right, now we're going to talk about the secondary injuries that occur from the primary injuries. And as I said earlier, you're going to have those can occur within minutes, hours, or days after the primary injury. I'm not going to talk about the biochemical reactions because the video you need to watch talks about that, gives good examples. But the bottom line is a lot of the secondary injuries are related to the edema that's caused from the primary event, and the edema causes an increase in ICP, and it causes inflammation of the tissue as well as brain tissue ischemia, and that's what the big problem is. This is a diagram showing the management of care with severe brain injuries. I need you to bring this diagram to class because we're going to discuss it, and there's a couple of updated changes on here that I need you to fix. The initial nursing assessment of a trauma patient uses the ABCDE trauma assessment: airway, breathing, circulation, disability, meaning neuro disabilities, and then expose your patient by taking all their clothes off, looking and doing a thorough head-to-toe, front and back exam to make sure they don't have any other injuries, and then cover them up because trauma patients are in a heightened metabolic state, and shivering increases the metabolic demands that they already have going on because of their trauma. This is the Glasgow Coma Scale. You've already had this. You need to know it for this test because patients with head trauma are going to be getting serial Glasgow Coma Scale scores done. Because a traumatic brain injury is associated with a cervical spinal cord injury, all patients who come to the ED with head trauma are treated as though they also have a cervical spinal cord injury until X-rays prove otherwise, as well as a physical assessment. And we'll talk a little bit more in class about how to assess the skin and all underneath and how to properly take off the cervical collar and roll a patient when they have, because trauma patients are going to have these C collars on for a while. You can also, patients with traumatic brain injuries can also go through neurological interventions. I'm not going to read all of these. The one I do need to explain to you is the decompressive hemicraniotomy with duroplasty. And what that is they'll take them to surgery, cut open take out a square portion of the skull, which is going to allow this, the brain tissue to give it a little bit more room for swelling without compressing all of the blood vessels. And then once the ICP goes back down and the swelling's gone, they take them back to surgery and put that portion of the skull back on. Care of a patient with a brain injury and increased ICP. You see a list of different things here. There's also an article I put on Canvas for you. I want you to bring that to class as well. And we're going to be talking about a lot of these different things. Avoiding noxious stimuli. The patients are going to likely be in the ICU, and that's very noisy between alarms and everything else going on. The nurses need to be mindful of that so that they can keep noise to a minimum, light to a minimum, touch to a minimum. So these patients are going to be, their care is going to be staggered, not clustered. And you also have to watch if visitors are causing an increase in the patient's ICP, you may have to ask them to step out, and that's totally appropriate. Also, assess for sympathetic storming. These are early and late cues for increased ICP. I'm not going to read them off here. You can see what they are, and you can see that they're going from least invasive to more invasive. So these are common things you're going to see. You just need to know them. Maintenance care of a patient with a traumatic brain injury. This is a sort of like an ICU bundle that they're going to do. DVT, PE, prophylaxis. Patients with traumatic brain injuries that are on ventilators, they're going to usually try to start, if they can't wean them from the vent, they're going to put a trach in them instead of keeping the ET tube in them, because that can cause, problems. So support the family and let them know that this could, this is potentially a temporary situation, but it's better for the patient because the ventilator acquired pneumonia that develops, the ET tube and the trauma from that. So be supportive with family members when they're talking about tracheostomy for a patient with traumatic brain injury. Seizure prevention, seizure precautions. You've talked about that. All of that comes into play. Normoglycemia, because patients with trauma have hyperglycemia, and hyperglycemia slows healing time, or it exacerbates the rate of healing. So you want to keep normal glycemia, adequate nutrition, and all of these other things listed, and we'll talk about that in class as well. The ICU A through F bundle. This is some of the stuff that's listed. Dr. Udo was going to go over that as well with sepsis and patients on a vent. You're going to have, or patients who are sedated, they're going to do spontaneous awake trials, and people on a vent are going to get spontaneous breathing trials if they can tolerate it, because the goal is to wean them off of the vent. Patients need to make sure that their sedation and analgesia is ordered and working. Delirium assessment, early mobility is always producing better outcomes in patients, and make sure that you engage the family or caregivers in care for the patient. Explain the procedures and all that to them, because that empowers them. This is some of the pharmacological therapy. Patients are going to either receive mannitol or hypertonic saline to promote osmotic diuresis and decrease ICP. Levetiracetam is commonly given for seizures. You have vasospasms. The nimodipine is for vasospasms, and then narcotic analgesics as well as sedation. And those are some of the common types of pharmacological therapy patients with TBIs are going to receive. Patients may have an external ventricular catheter and a drain put in to decrease the ICP by draining off CSF. A neurosurgeon is going to put it in, and then when the nurse handles it during cleaning or any type of manipulation, sterile technique, minimize dressing changes. If they don't need to be done, you don't routinely do them. And there's a video also that I put on the Canvas that you need to watch related to setting up this external ventricular catheter and making sure that it's level to the right area. So make sure you watch that video. This is a picture of an ICP drainage system and the transducer, which has that yellow cap on it, needs to be lined up with the tragus of the ear in order for it to give accurate readings. So again, watch that video and we'll discuss it in class as well. And lastly, geriatric considerations. Geriatric patients, because they fall, they're more apt to get subdural hematomas or cerebral contusions. You need to obtain adequate mental, behavioral, physical, psychosocial, and delirium assessments on your geriatric patients and screen them for self-care deficits and assess motor, balance, cognition, sensation, strength, as well as balance. And that is it. Thank you very much, and I hope that the content has been helpful.